Hello everyone, and welcome to today's presentation. I'm Dr. Asim Hussein, and I'm glad to have you here. Today we'll be discussing toxicology emergencies, focusing specifically on salicylate toxicity. Over the course of this session, we'll explore the key aspects of salicylate poisoning, including its causes, symptoms, and management strategies. I look forward to sharing valuable insights with you, so let's get started. Let's look at this case. We have a 42-year-old man presenting with tinnitus, vomiting, and rapid deep breathing following an aspirin overdose. The ABG results show a pH of 7.48, which indicates alkalosis, a PaCO2 of 25 mmHg, which is low, and a bicarbonate level of 18 mmol/L, which is also low. Now, these findings point toward a mixed acid-base disturbance. The elevated pH suggests alkalosis, but the low bicarbonate indicates acidosis, and the low PaCO2 shows respiratory compensation. In the context of salicylate toxicity, or aspirin overdose, we often see a combination of metabolic acidosis and respiratory alkalosis. The metabolic acidosis results from the accumulation of salicylate and its effects on cellular metabolism, leading to an increased anion gap. Meanwhile, the patient's rapid breathing causes respiratory alkalosis. So, putting it together, the pattern most consistent here is a combination of respiratory alkalosis and metabolic acidosis, which is a mixed disorder. That's why the answer is C, mixed respiratory alkalosis and metabolic acidosis. Understanding these patterns helps us interpret ABGs accurately and manage such toxic ingestions effectively. Let's look at the correct answer here, which is C now. The key point to understand is that salicylates, such as aspirin, can cause a mixed acid-base disorder. Initially, they stimulate the medullary respiratory centers, leading to early respiratory alkalosis. This is because the body tries to compensate for the toxic effects by increasing the respiratory rate, which causes a loss of carbon dioxide. But at the same time, salicylates also induce a metabolic acidosis. This occurs due to the accumulation of lactate and ketosids as a result of the drug's effects on cellular metabolism. So, in summary, salicylate poisoning causes this characteristic combination: an early respiratory alkalosis due to medullary stimulation coupled with a metabolic acidosis driven by lactate and ketosid buildup. Recognizing this pattern is important for diagnosis and management. Let's take a closer look at this question about salicylate toxicity. The table presents several options for clinical features, and we're asked to identify which feature indicates severe toxicity that requires ICU management. First, mild nausea only might seem like an uncomfortable symptom, but it doesn't usually signal a severe or life-threatening situation. Second, isolated tinnitus can be a sign of salicylate poisoning, but again, it doesn't necessarily mean the patient needs intensive care. Third, a normal ABG, or arterial blood gas, suggests that the acid-base balance is maintained, which indicates the toxicity isn't severe yet. Fourth, a normal respiratory rate is also reassuring, as it shows the patient isn't experiencing respiratory distress. Finally, altered mental status is a red flag. This suggests that the toxicity has progressed to a more severe stage, affecting the central nervous system, and typically requires ICU management. So, the key takeaway here is that altered mental status is a critical feature indicating severe salicylate poisoning. Recognizing this helps us prioritize urgent intervention and escalate care appropriately. Certainly, let's go through this slide carefully. The correct answer here is option E, which is marked with a check mark. Now, when we look at the explanation, it highlights several key signs that indicate severe poisoning. Specifically, AMS, or altered mental status, hyperthermia, pulmonary edema, severe acidosis, and hypoglycemia. These symptoms are quite serious and suggest that the poisoning has affected multiple organ systems, leading to a critical condition. AMS shows that the brain is affected. Hyperthermia indicates a dangerous rise in body temperature. Pulmonary edema points to fluid buildup in the lungs impairing breathing. Severe acidosis reflects a significant imbalance in the body's pH, and hypoglycemia means dangerously low blood sugar levels. Understanding these signs is vital because they help us recognize the severity of poisoning quickly. When multiple severe symptoms are present, it alerts us to act swiftly and provide intensive management. So, in essence, this slide emphasizes that the presence of AMS, hyperthermia, pulmonary edema, acidosis, and hypoglycemia collectively indicate a severe poisoning scenario, requiring urgent intervention. This ties back to our overall theme of early recognition and prompt treatment in poisoning cases. All right, let's look at this scenario. We have a patient with salicylate poisoning who is conscious, but showing signs of metabolic acidosis, with a pH of 7.31. Now, the key here is understanding what the most appropriate next step in management is. First, salicylate poisoning can cause a mixed acid-base disturbance, but metabolic acidosis is a prominent feature, especially in toxicity. The options given are intubation, IV bicarbonate, activated charcoal, calcium gluconate, and acetazolamide. Intubation might be necessary if the patient's airway is compromised, but it's not the immediate next step just based on acidosis. IV sodium bicarbonate infusion is a classic treatment in salicylate poisoning because it helps alkalinize the serum and urine, which promotes salicylate excretion. Activated charcoal is useful if the ingestion was recent, but it doesn't directly address the acidosis. IV calcium gluconate is usually reserved for calcium channel blocker overdose, not salicylates. And acetazolamide is a diuretic that can cause metabolic acidosis, which is not helpful here. Given that the patient is conscious, but has metabolic acidosis, the most appropriate next step is to administer IV sodium bicarbonate infusion to correct the acidosis and enhance salicylate elimination. So, in summary, the best answer here is B, IV sodium bicarbonate infusion. It's a targeted, effective approach in this context. The correct answer here is B now. Let's talk about why. Urine alkalinization, which means raising the pH of the urine to about 7.5 to 8, is a key strategy. When we do this with IV sodium bicarbonate, it actually helps increase the excretion of salicylates. This is important because salicylates are better eliminated when the urine is more alkaline. So, by alkalinizing the urine, we enhance the elimination process and help clear the toxin more effectively. This approach is a crucial part of managing salicylate poisoning, connecting to our overall goal of improving patient outcomes through targeted interventions. Now, let's look at why endotracheal intubation should generally be avoided unless it's absolutely necessary in cases of salicylate toxicity. The correct answer here is a risk of aspiration. When dealing with salicylate poisoning, the patient's level of consciousness can be compromised, and they may be at a high risk of aspirating gastric contents. Intubation itself, while sometimes necessary, can potentially increase this risk if not done carefully. Also, there's a concern that the procedure could worsen the patient's condition by introducing additional complications, such as trauma or infection. So, the key takeaway is that we want to avoid invasive procedures like intubation, unless absolutely needed, because they can pose additional risks, especially aspiration, which can further complicate the management of salicylate toxicity. This ties into our overall theme, understanding the delicate balance in managing poisoning cases and recognizing when interventions might do more harm than good. All right, let's look at the correct answer here, which is C now. The key concept to understand is what happens when hyperventilation is lost. When a patient stops hyperventilating, CO2 retention occurs. This is important because CO2 buildup leads to a drop in blood pH, resulting in sudden acidosis. This acidosis then causes an increase in CNS salicylate levels, which can worsen the patient's condition. So, essentially, the loss of hyperventilation shifts the balance, leading to CO2 retention, acidosis, and an increase in salicylate levels in the central nervous system. Recognizing this sequence is critical in understanding how changes in ventilation can impact salicylate toxicity. Alright, let's look at this question about salicylate poisoning. The options include a salicylate level of 30 mg/dl, isolated tinnitus, severe metabolic acidosis with altered mental status, mild respiratory alkalosis, and normal renal function. Now, the key here is understanding when urgent hemodialysis is indicated. In cases of salicylate poisoning, the decision to proceed with dialysis depends on the severity of the symptoms and the laboratory findings. For example, a salicylate level of 30 mg/dl might seem high, but it's not always an immediate indication for dialysis unless accompanied by severe symptoms. The most critical clue here is severe metabolic acidosis combined with altered mental status, which suggests significant toxicity affecting the body's systems. This situation indicates that the poison has overwhelmed the body's ability to compensate, making urgent dialysis necessary to remove the toxin effectively. So, the most important concept to remember is that when patients develop severe metabolic acidosis and mental status changes, they are at high risk, and prompt hemodialysis is indicated to prevent further deterioration. Connecting this to the overall theme, it's essential to recognize the signs of severe poisoning early, so we can intervene promptly with treatments like dialysis to save lives and prevent complications. Alright, so the correct answer here is C, and let's talk through why. Dialysis becomes necessary when the patient is experiencing severe acidosis, which means the blood pH is dangerously low. It's also indicated when there's altered mental status or AMS, indicating significant neurological impact. Additionally, if the patient has renal failure, their kidneys can't filter waste properly, making dialysis essential. Pulmonary edema, which is fluid buildup in the lungs, can also be a sign that dialysis is needed to remove excess fluid. And finally, very high levels of certain toxins or electrolytes in the blood are clear indicators for dialysis. So overall, dialysis is a critical intervention in these severe cases to restore balance and support the patient's recovery. This ties into our broader discussion about managing complex renal and metabolic conditions effectively. Let's delve into the pathophysiology of salicylate toxicity. When salicylates are ingested in toxic amounts, they stimulate the respiratory center in the brain. This stimulation leads to an increase in respiratory rate, causing what we call respiratory alkalosis, where the blood becomes more alkaline due to excessive CO2 loss. At the same time, salicylates uncouple oxidative phosphorylation in the mitochondria. This disruption impairs normal energy production, leading to a buildup of metabolic acids and resulting in metabolic acidosis. Additionally, this process increases heat production and glucose consumption. Patients often experience hyperthermia and may have increased metabolic demands, which can further complicate their clinical picture. Recognizing these mechanisms is crucial because they highlight how salicylate poisoning affects multiple systems, emphasizing the importance of understanding and managing the underlying pathophysiology to treat toxicity effectively. Let's take a closer look at the key features of salicylate toxicity. First, you'll notice symptoms like tinnitus and tachypnea. Tinnitus, or ringing in the ears, is often an early sign, while tachypnea indicates rapid breathing, which helps the body get rid of excess CO2. Next, hyperthermia is another important feature, reflecting the body's increased metabolic rate and heat production. We also see metabolic acidosis, which occurs because salicylates disrupt normal metabolic processes, leading to a buildup of acids in the blood. Sometimes, hypoglycemia can also occur, complicating the picture further. Other signs include pulmonary edema, which is fluid buildup in the lungs, and confusion, a sign of central nervous system involvement. All these features highlight how salicylate toxicity affects multiple organ systems, emphasizing the importance of early recognition and management to prevent severe outcomes. Let's talk about management strategies for salicylate toxicity. In the early stages, activated charcoal can be very effective in binding the toxin and preventing further absorption. It's best to administer it as soon as possible after ingestion. In addition, intravenous sodium bicarbonate is often used to help alkalinize both the serum and urine. This alkalinization promotes the excretion of salicylates, which are weak acids, thereby speeding up their elimination from the body. It's important to avoid intubation if possible, because airway management can be tricky in these cases, especially if the patient is agitated or vomiting. We want to minimize risks associated with airway compromise. However, in severe cases where toxicity is significant, hemodialysis becomes a crucial option. Dialysis can effectively remove salicylates from the bloodstream and is often life-saving in these critical situations. So, to sum up, early intervention with activated charcoal, serum and urine alkalinization, and careful airway management are key, with hemodialysis reserved for the most severe cases. These strategies are essential to effectively manage salicylate toxicity and improve patient outcomes. Let's talk about pearls related to salicylate toxicity. A key point to remember is that mixed acid-base disorders are quite common in this context. Even if serum levels of salicylates are falling, that doesn't necessarily mean the patient is clinically improving. It's important to look at the overall clinical picture, not just the lab numbers. Now, when it comes to treatment, dialysis plays a crucial role. It doesn't just remove the salicylate from the bloodstream, it also helps correct the acidosis that often accompanies toxicity. This dual benefit makes dialysis a vital intervention in severe cases. So, to sum up, always keep in mind that serum levels are just one piece of the puzzle, and that dialysis can be a powerful tool to address both the toxin and the acid-base imbalance. This holistic approach is essential for effective management of salicylate toxicity. Thank you so much for your time and attention today. I really appreciate the opportunity to share these insights with you. Remember, the key points we've discussed, whether it's the importance of our approach, the strategies we've outlined, or the future directions, are all aimed at helping us move forward more effectively. I hope this session has inspired some new ideas and a clearer understanding of how we can apply these concepts in our work. Again, thank you for being here and for your engagement throughout. I look forward to seeing how we can all take these ideas and make a positive impact together.